I am, who is very honored to be invited here with you today. Basically, my experience, I misinterpreted a little bit the title of the talk. I will be focusing on thrombolytics, not so much on antithrombotic, but we can still discuss anything at the end. Related to this lecture, I have no disclosures at all. Just want to remind that at least in my circle, we talk a lot about thrombectomy all the time. We need to remember that thrombectomy is going to be applied to a minority of our patients, and lytics still to a substantial part, hopefully to 1/4 of our patients or even more. In Europe, where I practice, there is a huge variability in the access to lytics. We, as I said, we should aim to 25% or more. The best placed in this race achieve 20%. However, the mean rates is treating 7% only of our stroke patients with lytics. And the European Stroke Organization targeted that a reasonable goal would be to treat 18% of the strokes with TPA. We're still far away from that. In Europe, I'm sure it's also the case here. Let's see a little bit about the history of the agents. I think I thought it would be interesting to have a short review of the first, second, and third generation of agents and how they helped us. It's always fun to look at some history. How was the discovery of some substances generated by Streptococcus that would dissolve clots in tubes? As you can see here, like adding some of this substance that they call streptokinase was able to avoid clotting. And by the mid of the last century, the first reports of clinical effectiveness of this drug was reported, and this is very cool. I think it's the first series of thrombolysis. It was given intravenously, but with an angiography, they confirmed recanalization of the MCA that is back in 1958. But you can see that the treatment was given over hours and over multiple days, so a complete different concept. So that evolved over the years to what we are having now. It was not until 1993 that the first IA thrombolysis was administered successfully, as you can see here, in a basilar artery occlusion, again over a 2-hour infusion. Today it would seem still awkward, 2-hour infusion, right? But soon they realized that these first generation drugs, streptokinase, urokinase, was leading to unacceptable higher rates of ICH, and in the 90s, the MAST trials confirmed too high, and those drugs were basically abandoned. But you can see that the way to give it was over 4 hours during 3 days initially, which is at least curious. So what we know as TPA was originally termed as fibrokinase. It was discovered before 1950, and initially it was extracted from melanoma cells and then produced as a recombinant drug in 1983. The first trials for stroke date from the 90s, in which they were finding the correct dose, the correct timing of administration, and with this study, I think the modern era of stroke started. This is right when I started my residence a few years later, and I got into the neurology world where we were implementing the results of the NIDS trial, and there was a big revolution in the hospital where I worked, and that led that I was interested by stroke during my residency, and then I dedicated my career to stroke. Most interestingly, this I found a very nice way to show how TPA is especially effective for stroke, but for these moderate strokes. So for these very mild strokes, the difference between TPA and placebo in terms of favorable outcome is very low. Same with very severe strokes. So this is an effective drug, but mostly for this mid-size, moderately disabling mid-size clots in which TPA would work. Otherwise, we're not doing much of the difference. Over the next years, we tried to expand the time window unsuccessfully, up to 6 hours. Most that we can get was finding some effect up to 4.5 hours, and this is where we really are as of today. Since 2007, in which we published the ECAS-3 trial, but all these trials helped us to determine this sentence, that I also think it's very appropriate. We're in front of one of the most time-critical diseases in medicine. And this is why, if we dedicate your practice to stroke, you all the time live on the edge, on your cell phone, and on these apps that are warning us all the time there's a new patient and we need to act immediately. And this is a different kind of doctor than most other specialties. Now, in terms of intraarterial use, pro-urokinase also showed, and I saw this paper because it's also when I was starting my residency, but the way we used to administer these drugs was like this. We were navigating a microcatheter to the clot, and we were infusing over 2 hours the drug in the proximity, in the vicinity of the clot. And that sometimes, and this trial was positive despite the rate of reperfusion, what we call complete reperfusion, was only 19%. This is ridiculously low if we compare to what we are able to achieve in 2023, 25 years later. But it was still a positive trial with a thrombolytic drug. So as I said before, in 2007-8, we were able to expand the time window of thrombolysis up to 4.5 hours with this moderate effect. In fact, as we go further in time, the effect decreases, and we were never able to show that in unselected patients or patients selected only with CT, we can benefit beyond 4.5 hours, right? We were able to do that using what we called advanced imaging, like perfusion-guided, and CTP maps may help us identify the patients that benefit from TPA beyond 6 hours, up to 9 hours. Still, in many places, we are not able to offer this imaging technology right away. And also for unknown onset, the concept of the diffusion flare mismatch, when the lesion is not evident on flare, it means that probably we are not very far away, or probably within 6 hours from onset, and in these cases, patients benefit from TPA. Now, yes, if you look at all these trials with this advanced imaging, you can confirm that using these imaging methods might be used to indicate thrombolysis beyond 6 hours. But since we are one of the most critical diseases in medicine, this is how we practice. We try to be always pre-notified and to wait for the patient at the door. We use these apps to alert everybody, and we give the IVTPA as soon as possible after plain CT on the CT scan. And if needed, we do additional imaging. But we're aiming to achieve door-to-treatment times of about 20 minutes from arrival to the hospital. But what are the reasons that we are not administering IVTPA to a higher rate of patients? What are the barriers? But mostly is that presenting out of the time window, but also the reluctance of some physicians. And how can we tear or break down these reluctances? We all fear bleeding, but if we understand the relation or the causes of bleeding, we may be able to drop these barriers. Bleeding is not always the same. In fact, the bleedings that you can see on the left, the very mild, are usually associated even with good outcomes. It's a sign of reperfusion, and only the parenchymal hematomas lead to bad outcomes. And we have to keep this in mind. Yes, in very little number of patients, we may harm the patient with TPA. Unfortunately, despite we do everything correctly, we increase in 3 patients out of 100, we harm them. But on the other hand, we are improving the fate of 32. And this obviously is very graphically here, depends, time dependent. And if we were able to treat the patients within 1 hour of symptoms onset, as you can see on the right, the proportion of patients that we will be helping would be huge. Now, how can we drop these barriers? Yes, but by avoiding protocol violations. And protocol violations, you can avoid them with experience. So high volume centers have less protocol violations and less complications such as bleeding. So have in your mind a list of all the contraindications that you quickly can go through is what we should be doing. And also take a few minutes to talk with the patient's family, gather all the information that can be necessary at this point to better select the patient. And if you explain everything to the family, the pros and cons, the probability that everything is going to go well, and the little probability that a complication occur, that will help a lot in case of complications. So you see, I have very short time, but when I started doing my residency, we were monitoring with TCD, and this is my first paper in stroke 20 years ago. I'm becoming old, but we were monitoring what happened during thrombolysis, and we find out that it's very unlikely that a large clot like this in the ICA would recanalize, and this is the reason I became an interventionalist, because I wanted to get rid of these clots, and I realized that it wouldn't be possible with lytics only. We were monitoring what happening with these clots. We find out that yes, spontaneous recanalizations occurs most of the time without treatment, but too late, and that induced recanalization, the earlier it would occur and the more complete it would be linked to better outcomes. And also the clot, as we were discussing before, but the clot, the longer it sits in the artery, it will grow, it will be compacted, and more difficult it will be to be lysed by thrombolysis. Also, we defined the patterns of recanalization. It could be sudden, stepwise of flow, and obviously the sudden recanalizations would be the best. And it was very fun to objectivated to see them with TCD, how you could achieve this suddenly recanalization on the MCA. Sometimes you had reocclusions, which were as bad as not to recanalize. So we need to know that this happens, and we were able to associate some factors in the blood of the patients, antifibrinolytic agents that would preclude thrombolysis, or even the high rates of glucose would also interfere with thrombolysis. Coming 2 more minutes, but for those who may not know, ultrasounds also helped us in the effect of TPA. We were monitoring for 2 hours, but the ultrasound also had this beneficial effect in lytics, and we were improving the rates of
you need to conclude your...
I will. Okay, I'm concluding. Well, with that was too long. Microbubbles also enhance the effects of lytics, and we were even giving intraarterial microbubbles with lytics. And at some points, we even were able, with the microcatheter, to perfuse blood through the occlusion. As you can see here, manually infuse blood through the occlusion to artificially advance reperfusion to the ischemic lesion. Basically, I don't know, I'll stop here, but I wanted to comment about new lytics and expanding the time window. I will go straight to my conclusions for the sake of time, but basically my conclusions are that within the 4.5 window, we should find a very good reason not to treat with TPA a patient. We can expand the time window after 4.5 hours with what we call advanced imaging in some cases. And also I wanted to talk about newer lytics like tenecteplase that is cheaper than TPA and is non-inferior for sure, and probably in some cases superior to TPA. And finally, there is very promising results of expanding the time window, especially for non-LVO stroke patients with agents like tirofiban. So there's a lot of hope, a lot of progresses that are being made in the field, and that's it for me. Thank you for your attention.